So I'm going to make the presentation for our two next speakers. There's almost a conflict of interest. I know them well. They're my associates. They put up with me every day. We don't often see them. I'm not going to make a scientific presentation of these practitioners. I'm going to do it with affection. Marie-Pierre Labadie, who's a dental surgeon in Toulouse, who's a machine to operate in our clinic. I'm glad she's here today. It means that she's not in the operating and she's taking a rest and making this presentation. She's a specialist in surgery, but also in buccal dermatology. And you can talk to her about this later. She's the one who takes care of these types of lesions in our clinic. So Arnaud L'Homme is also an incredible dental surgeon. He's the Swiss knife of our clinic. He knows everything about everything in terms of bibliography. I'd like to thank these two practitioners and thank them for working with me every day as a surgeon. I'm really proud to work with them. They're going to present a retrospective study on guided bone regeneration. It's always a bit difficult to see these cases as we run through them, but it's a little game that we have. We finish by looking at all of our cases one by one to make sure that it's working, because it's great to present cases and to take great photos of surgery. I really appreciated the written introduction of Bernard Chapotat on the fact that it's not just surgical technique, but why we do it. And I'll leave the floor to Arnaud and Marie to present a retrospective study of what happens to vestibular GBR. So we can't hear Marie-Pierre, apparently. I'll use this one. I have problems with digital technology. Thank you, Chairman. We wanted to present this study on the future of vestibular GBR. We're 4 practitioners in our clinic, 4 oral surgeons. What happens to these guided bone regenerations, and do they melt like snow in the sun? Why are we asking this question? Simply, we all use the same protocol. We use the same GBR technique, and we've always systematically, in the first quarter after surgery, a 3D cone beam to verify the sustainability of our construction. And generally, we're satisfied when we place the healing screw. We do another 3D when the implant has been loaded, 1-2 years and more. And we realize that in some cases, the X-ray result is not satisfactory, even if clinically everything seems fine. So based on these X-ray observations that are disappointing, there are 4 of us, and we all try to explain. I explain it works more on one side than another, that a technique will work better than another. We change technique, and we're swimming in subjectivity, so that's not a good situation. So we asked a student to carry out a retrospective study on the cases that we had performed in our surgery for her thesis work. So I'll take advantage of being on stage and of presenting this work to thank Dr. Nela Boudaoui. We couldn't have done this work without her. She did a huge amount of work, and the analysis that we did took a lot less time than it took her to acquire all of the data. This is a retrospective study for a thesis managed by Dr. Courtois and myself, so there is a bit of a conflict of interest, and I'd like to thank Dr. Verne, who's an expert epidemiologist at the university. So it's a retrospective study. From a clinical standpoint, it was vital. It allows surgeons to have a different look at their surgical activity to see if I worked well, do I need to change anything, and what are the variables that I need to act upon to get better results. We have a retrospective study in one center during which our student, Nadia Boudaoui, looked at 170 patient histories for 295 implants. To get statistically relevant results, we selected patients on the following factors. We had to have a pair-implantary GBR. It has to be a reinforcement or a reconstruction GBR class 2 or 3, so there has to be vestibular bone that guarantees that under the pressure of the implant that it will melt and we won't have it vestibularly anymore. Class 3 corresponds to reconstruction GBR above the exposed spires. All of the cases were used biomaterial, allogenic bone biobank. It's the only one we used in this study, so that reduces the variables, and systematically cortical cancellous bone. So we used Krios membrane without a membrane, PRF, and CAB. We also selected the patients based on 3 CBCT exams, pre-op, post-healing, and post-prosthetic. The post-prosthetic examination, either because the patient needed another cone beam, and so we checked it at that time, or the patient came back after 1.5 years, 2 years after we placed the prosthetic and accepted that a cone beam be performed, so they consent to the use of the cone beam. In the end, 132 patients were selected, 237 implants, and they're all global D in cone.
So we've got 96 women and fewer men with an amplitude of 20 to 80. So 5 cases were excluded. The 5 cases are peri-implantitis cases. This took away the tissue around the implant, or there was an infection. So when we saw the patients again, so we don't do the prosthesis, but we see the patients afterwards. But we were quite pleasantly surprised to see that in cases like the one that we're going to show you, we've got this problem, this suppuration problem. We don't know how long it's been there, so we do the 2D X-ray with the proximal bone, but the 3D X-ray shows us that the cortical bone has been maintained at the collar of the implant. So the acquisition of data is based on 2 cone beams. Initially, we had a machine, the CS9300, that allows us to acquire data before the operation, but the quality didn't allow us to read the bone volume of our implants from a vestibular point of view because of the metal part of the implant. So we had to wait for the CS9600 machine. This is the machine that we used so that we could reduce the bias. But any kind of cone beam device today with a 120 kilowatt ray can produce the same result. In other words, you can get over the problem that you've got the shadow of the implant, and you can read the vestibular bone volume quite easily and specifically. So we've got before and after the prosthesis, and the average time between the implant was given to the practitioner and the time the patient was seen again. So the average time is 2 years. And we can see that the results are clinically satisfactory without any bleeding. 2 cases had to be checked up on over a 2-year period because of the vestibular bone problem. So I'd like to pay tribute to Nadia, who spent a lot of time making all of these measurements. What we're going to be presenting to you to do is we're going to present to you these different measurements. We're looking at the bone height, the overhang of the bone, and then the thickness of the bone at the collar of the implant, and the thickness of the bone lower down in the middle of the implant, or in some cases where you actually have the first visible level of bone. So this collar bone is said to be the critical zone in literature today. It's the zone where all teams involved in GBR with implants have a problem where the spires become naked when they are doing their post-op X-rays. When you look at the share of sites with these different implants, the 237 implants, so they correspond to absent teeth that require regeneration. There's an inequality of share of distribution, and this can be explained because we weren't able to make measurements tooth by tooth because some measurements would have had no statistical meaning, so we did not do these measurements. Now, concerning the results. So we've got 2 categories of results, favorable on the left-hand side with a J value that is positive, which is below the implant, and then there's J negative with a bone that has migrated from where it was positioned during the GBR. It's just a bit lower than the implant. So in over 70% of cases, the bone is present above the collar of the implant. So a GBR bone with halogenic bone, with or without a membrane, but we'll talk about that later. After being put into place, it can be stable and seen above the collar of the implant via X-ray. In 22.7% of cases, we lost bone. Now, this situation has no clinical consequences at 2 years when you see the patient, but as we know from literature, this means that there is a bed of complications, peri-implantitis and other complications, which will lead to the loss of the implant and the unhappiness of the patient. So the work involved studying the problems relating to this bone loss. But before going into that, let's come back to a value. It's this, the J positive value. The average of bone measured above the collar was 1.33 millimeters. This is an average close to the median. It shows the stability of the result. And with an amplitude that goes from 0 to 5 millimeters, 0, because if we consider that there was no bone above the implant and if we hadn't lost any bone, it was nevertheless a success factor. And the value that goes down to 5.5 millimeters above corresponds to the case when implants were very much buried and you've got bone that grows as you know, this is possible. From a clinical point of view, this is a young girl where we had to work on 31 and 31. So we had a failure of an autogenous graft beforehand. So we decided to insert the 2 implants. So GBR with halogenic bone and different criteria that are used by the dental surgery. So before the healing screws are inserted, we've got the volume around the collar that is quite satisfactory. And what we're hoping here is that this lovely volume is, thanks to the handling, will become corticomedular bone. So we've got the Holy Grail. We've got an X-ray that's very good with bone with corticomedular differentiation around the implant, and then differentiation, this image that we have, this is going to guarantee in the long term that the tissue around the implant will resist to mechanical forces and any kind of biological problems. So if we want to go a bit further in the analysis of these favorable results, so the 77.3% of cases in our study, and if we measure the bone thickness, the vestibular thickness at the collar, it is 2.14 millimeters with a fairly small standard deviation. If we look at the maxillary results and the mandibular results, they're fairly similar with about a 1 millimeter difference. And this bone thickness is very important because it represents, according to us, a corticomodular biological unit. It's the necessary thickness to see on the X-ray the cortical and the medular aspect. We know that the bone can adapt to stress or adapt to a bacterial infection. So this is supported through literature. All of the literature says that below 2 millimeter of thickness, we can't guarantee the future of the bone around the implant. Now, this bone that provides for gingival support. For this patient, we've got two different cases. Number 11 was rehabilitated 10 years ago with a GBR, with a xenograft, and the results are lasting from a peri-implant point of view. And then there's an in-cone implant and a GBR with halogenic bone. That's the second case. Radiologically, we can see that the halogenic bone gives us the corticomedular difference, and the aesthetic result, the biological result, are both stable. But we also have stability when it comes to the xenograft used 10 years ago. So everything is stable. However, what we don't know with this patient is that around number 11, we've got purely cortical bone, or whether we've got bone, a xenograft which has been fiber integrated, or whether there's a corticomedular difference. But this is not possible to see from the X-ray. So let's move now on to the less favorable results. So we'll refer to them as unfavorable results, even if clinically these are situations that are quite stable. So bone loss around the collar of the implant. So it happens in 22% of cases of our study. So we've got an average loss of 2.24 millimeters. The median is not as bad. It's 1.35 millimeters. This can be explained by the amplitude of values measured that go from 0.2 millimeters to minus 10.5 millimeters. And these values that we will refer to as extreme values in the rest of our presentation are values that we have put to one side because the values at over 5 millimeters were not very present in our study. They only concerned 8 implants out on 6 patients, and if we get rid of them, we realize that the loss around the implant collar is reduced to 1.35 millimeters, and that's really not very much. It corresponds to the first spire or the start of the second, and it's tolerated in many systems. But for us, in an infracrestal system like the in-cone implant, we want bone above the collar of the implant. So from a radiological point of view, we're often disappointed with GBR. And with the case of this patient who comes for the root extraction, we use the operation to see what's happening around the implant. Clinically, the result is not too bad, we can see, even if there's a little bit of an exposure of the abutment. We've almost got an extreme loss along the cortical bone area, but when we looked under the flap, we realized that there was bone. The problem is that we don't have the 2 millimeters necessary to be sure that the implant will last over time, but we have the bone film that cannot be seen on the X-ray. So it's this bone film that tells us that there is a clinical result, but we don't know whether it will be lasting. So if we go a little bit further in the analysis of this unfavorable data, the measurements, and we measure value E, we can see that the thickness, when you can be measured at the lowest level of the bone after apical migration, it's 2.21 millimeters with a standard deviation of 1.6. It's almost as if the bone was trying to recover the thickness, the 2.2 millimeters, to ensure some kind of vestibular stability. So once all of these measurements were done, we wondered whether it was possible with our sample to have a kind of multiple variable analysis, a kind of multiple variable analysis. I'm saying kind of because it's always difficult to do something that is significant. We wanted to know whether it was possible to individualize one or several factors that might have been responsible, or risk factors responsible for the cervical bone loss. So all surgeons who work in this area, who wonder about the reasons for failure, often talk about the anatomical site, the maxilla, the mandibular, the general state, the type of membrane used. If we haven't always used resorbable membranes, the type of GBR, the appearance of complications, did they have an effect on the final result? What about the occlusion forces, the position of the implant in the corridor, the vestibular corridor? Did that play a role? The quantity of bone as well, that's another thing. So clearly, inside the study, we can say that neither the gender or age of the patient had an influence on the results. Now, concerning the general state, only 46% showed an alteration of the overall state. So 46 patients, sorry, I got that wrong, not 86, 46. 46 patients with an alteration of the general state, generally marked by high blood pressure, and then there were patients suffering from osteoporosis, diabetics. There were patients with VIH following tritherapy, patients with treatment for breast cancer, and patients with treatment for acne. So if we look at the results, we can see that we're still in a G-positive situation, a J-positive situation. So for hypercholesterols and people with high blood pressure. So in our study, it's impossible to correlate the general state of the patient with the result of the GBR operation. So we also wondered whether there was a difference of results between the maxilla and mandibular areas in terms of positive and negative results. So the sample was fairly homogeneous. Homogeneous in terms of maxilla and mandibular works. And with respect to the operation, so we had 17% positive, 23 who were negative. We had exactly the same distribution. So we can deduce from this that the difference in terms of natural structure that you have between the maxilla and the mandibule doesn't seem to have an effect on the cervical bone loss. Now, in fact, and this makes us curious, the mandible that we might have imagined, this dry bone, which is not as well nourished after GBR, contains only one of the extreme negative values, a loss of over 5 millimeters in vestibular terms. The others concern the maxilla operations, and we'll try and find other factors to explain this. We also looked at the type of membrane used. Did it have an impact? We used a hollow membrane in most cases. We used a PRF membranes. In 3% of cases, there was a cover as well, a protective cover that was used as well. When we compare the profiles, the success and failure profiles, we find ourselves with profiles that are fairly similar, with a slight advantage with the Creos, where the results are slightly more positive. You can see the figures on the screen, but at least these results are not very significant. Now, concerning just one last thing, it's important to note at this stage that only 5 cases of Creos membranes were fixed or were pinched, as described this morning in the protocol with the non-resorbable membrane by Dr. Chieta. So the fixing of a Creos membrane, when it's resorbable, when you listen to the salespeople, the membrane can be fixed or not fixed. So for many years, we decided not to fix the membrane, but given the results, we had to change the way we went about things. And now all membranes, resorbable membranes that are used, are systematically fixed, so that we can use the technique described by Dr. Urban, which consists of creating a kind of a fatty pad, so that there's a little bit more support and a slight compression, because that compression might be necessary when it comes to the implant, but this will be the subject of a future study. Now, just like the use of other techniques, you know that inside the surgery we've made this systematic when we're talking about graft reconstructions. In the case of the study, you've only got 3 cases, so not very significant, but we've made it more systematic for GBRs that are very wide. For the maxilla aspect, we'll present perhaps the results of these studies a little bit later on. Now, maybe there's a take-home message here. The PRF, is it as efficient as the Krios given the results that we have? That might be the question. Well, given the results, we can't say that PRF is as efficient. If it's used, we don't know whether it's as efficient as a non-resorbable membrane that's not fixed. So that's why we systematically fix our membranes, so that for later studies we will have better results. So we also wondered whether the type of reconstruction, the objective of the reconstruction, whether it was to reinforce or reconstruct, and did this have an impact on the final result? So a reinforcement GBR, this is something that we see on the left-hand side. The implant has to have a fine film of bone, whereas if it's for reconstruction purposes, the implants are inserted with spires that are fairly well exposed with no native bone, and so it's important to rebuild the bone volume. So you can see the different cases in terms of reinforcement and reconstruction. So this allows us to compare. This comparative study is without appeal. Clearly, there is a much more favorable situation, and it's much more unfavorable when you've got a reconstruction range. So this is supported by the statistics that are significant. So it's interesting to note that at this stage, any extreme loss appeared on cases of reconstruction. So this means that, look, if you take our study, the reinforcement proves to be more stable than the per implant reconstruction, and that the reconstruction GBR seems to be a risk factor when it comes to bone loss around the collar of the implant. So there are still a lot of questions. So this is a patient who, during the same operation, benefited from the reconstruction of the posterior maxilla area with a graft, an allogenic bone block, and GBR. When we opened up the patient to insert the implants, the crest on both sides were quite satisfactory in terms of thickness and height. There was good vascularization, so we knew that we could insert the implants in good conditions. So we had them down by 2 millimeters. Everything seemed to be going very well. Unfortunately, when we did the 3D 2 years later, we saw that on the grafted side there was a big difference in terms of the stability of the bone from a vestibular point of view. Now, with respect to the 2 implants in the GBR, we've got a dissatisfactory result from an X-ray point of view, with bone loss. So next factor, we wondered whether... Sorry, can I just add something? Sorry. So the question that we asked ourselves, and we'll come back to it later on the right-hand side, we've got a graft reconstruction. On the left, it's a GBR. We're wondering that if for big expanses like this, whether GBR has enough mechanical resistance to meet the stress that it undergoes. And we deal with this in the study. So if we ask about the effect of post-op complications that patients see after GBR and other operations at the same time, there were 11 patients for whom we had to there was the necessity to see them to check for inflammatory responses that lasted for more than 3 years. So when you have pain and inflammation that lasts beyond 3 days, you have to see the patient again. And all of these patients who were checked up again after 3 days, all of these patients who had a big inflammation or an infection and needed a change in treatment, they were analysed. 6 of the patients had a J positive value after the healing period and after the implant had started to work. For 5 patients, 5 implants, unit implants, the value became negative. So what does this teach us, the analysis of this second category, the unfavourable category? We see that GBR for reconstruction or reinforcement was not a decisive part of the complication. It's difficult to draw conclusions, in fact, when it comes to complication, but we can see that the share between favourable and unfavourable cases is in favour of the unfavourable cases. So we can deduce from this and conclude from this that the emergence of inflammation after operations seems to have an impact on the result at 2 years. We also wondered how bone loss might develop. When you see that there is bone loss after 2 years of inserting the implant, you have to look at the initial size. And when you look at the initial size, after the healing screw has been used, there are different categories. One category with patients with bone above the implant, that bone that has been lost once the implant has been inserted. That's 60% of cases, and the 30% of remaining cases are cases where bone had already been lost during the healing screw checkup. So when you look at the figures, what we're seeing is that the average value of J for patients having lost bone was 1.8 millimeters. It remains stable when you check this 2 years later. But that value that is initially positive, when it is due to mechanical stress because of occlusion, this means that there is 3.2 millimeters of bone loss. Now the question is, and this is what we see in the literature, is the material resistant enough to resorption? Need we find better material? This can be found. There are materials that are more resorbable and there are materials that are not resorbable when they're homogeneous, when there are different synthetic materials, for example. So do we need to continue to fight against resorption? Because all of these materials show that they are able to be resorbed. Now, just to illustrate all of this, once again, figures are not my thing, you will have noticed. Here are some illustrations then. We decided to carry out a study on teeth that seem to be the teeth with the highest amount of mechanical stress, the premolars and the canines. So when we look at the results in terms of the primary molars, we can see that the results are the same than as for those for the study population. But when you look at the 13 and 23 cases, the result is much more positive compared with the rest of the study sample when it comes to these canines. So how come? Why is that? There are several hypotheses. The first hypothesis is, are we overcorrecting? Are we overcorrecting because we want to reconstruct the canines? But, you know, we're doing the same thing with number 16 because we want to rebuild the zygomatic pillar, the abutment. So the second hypothesis is, what about the setting of the occlusion? Does that have an impact? Once again, there are many practitioners who do this, who work with prostheses. There are many ways to set the occlusion. There are many ways, many profiles. Do you have a tulip form or not? But the question is, there's no bone loss because they're very careful about the canines when they're setting the occlusion dynamically, in which case that encourages a group function in order to protect the implant, or on the contrary, with if you have a more dynamic, more detailed dynamic occlusion setting, you simulate the bone, and this helps the bone to be maintained around the implant. So the last hypothesis concerns the position of the implant itself, because from an aesthetic point of view, we saw this with the maxilla, we saw this with Bertrand, we tend to insert the implant palatally, and this palatal position of the implant actually protects the reinforcement. So it's much more solid, and therefore it resists better to mechanical stress. So these are the different hypotheses that we have to explain this result. In order to go a bit further with respect to the effect of the position of the implant in the corridor, we tried to distribute the population. So share them between three categories. The first category is where you have the implant collar from a horizontal view, as we can say. So that's the cone beam on the left-hand side. It was in the vestibular position, in the vestibular portion of the prosthetic corridor. The second category corresponds to a position of the implant that is centered in the corridor, and this third category corresponds to a palatal position. So it's against the palatal wall or the lingual wall. So when we look at what is favorable, what is unfavorable, we can see that when the collar of the implant is vestibularly positioned in the corridor, we can see that without surprise, in all cases, there are implants that are not aesthetic, and that's because we got the positioning wrong. When it's in too much of a vestibular position, we've got a 50-50 share between favorable and unfavorable, in spite of the regeneration. When it's perfectly centered, the implant, we've got exactly the same statistic with respect to the overall population. When it's positioned against the palatal wall, this seems to provide protection, because the GBR is much more satisfactory in this case. And you will note that the values measured, however, are still identical when you compare them to the overall sample. So you've got unfavorable cases that need to be questioned. It's very interesting to note that these results in our study are the most significant results found, with 0.005. That's the kind of level of significance that we have. Now, just to continue, so that there is this feeling now that the more bone we have, the better it is for reconstruction purposes. And this feeling, we realize, could only be corroborated, we realized, by scientific studies that confirmed that the bone gain is better when the native bone volume is greater. So very few authors have actually focused on the effect of this bone volume overall before the implant is inserted, whether that provides some kind of gain in terms of the quality of the GBR post-op. So many colleagues have published articles, and here's an article where we look at the festonnage, where we classify. There are three cases, in fact, depending on where the feston is, and they concluded that the bone gain by GBR, when it's a bit, it's bigger when it's over the implant, and so this is backed up by. So once again, this was not enough to protect against resorption, even if it's not very resorbable. So we wondered whether there was a bone morphotype that is better than others in order to maintain the space in terms of its vestibular position. So we redispatched to the different cases. We reclassified the cases in three categories. The first category is considered as type A, so the window type. The case where your root seems to move away from the bone is no longer open, either cortically or corticomedullarily. So this is a situation that is often associated with gingival periodontitis, and we know that it can be quite serious.
Type B est un type.
The second category, type B, is cortical. So this is a type where you only have cortical bone in the vestibular adjacent to the implant. So this cortical type corresponds to this bundle bone. So it's this bone that we know it's going to erase when the tooth is extracted, and then we have this corticomedular bone where we have cortical and vestibular bone around the teeth, so the teeth are bathed in bone mass, and these are very favourable cases because we have a remarkably satisfactory bone quantity. And when you look at the results based on the same principles, you can see that the type A, fenestral type, is extremely unfavourable for the maintenance of our GBR. Then type B, the cortical type, is more favourable in general population, and this is increased yet further with the type C, which is corticomedullary. So here again we have some very significant results. So type A is a type where we tend to lose our GBR a lot easier. So are there any cases where we combine two types, the unfavourable case, type A, and the poor position of the implant? Yes. In fact, we've got 8 examples in our study, and here clearly when you look at the results of the study, there's only one single positive case. 7 cases are negative, so this is the poor positioning of the implant, and combined with type A, this means that the GBR is almost definitely going to fail. So by way of conclusion, because obviously there are a lot of figures, you've probably fallen asleep by now, just to give you some more clinical information, in this study we have highlighted the fact that 77.3% of results in GBR were radiologically favourable at 2 years, and 22.3% of cases, the GBR cases, are clinically favourable but radiologically less favourable, giving us less safety and less security for the sustainability of the implant in the mouth. And then when you look at the risk factors, the first risk factor is infectious complications, and I don't really see how we can prevent this apart from checking that hygiene rules are optimal in our operating theatre. But the main point here, or the main reason for these complications, depend on the patient, obviously, and general health is not a factor that we have identified as a risk, so it's difficult to anticipate on this. However, rejection of reconstruction is unfavourable. So basically we've changed our protocol since then, because in fact this is a presentation we should have given 2 years ago. The figures were published 2 years ago. We've changed our approach, and now we avoid what we call so-called reconstruction GBR. So we prefer to have pre-implant reconstruction and then install the implants later on. So this is what you see here in this case, where we chose a GBR, long range maxilloposterior, and it went very well. The rich reconstruction went well. Then we placed the implants 50 newtons submerged, and then we have immediate loading, so in the sector 1, and then at 6 months you can see that the result is highly satisfactory. Then if you do a 3D scan 3 years later, once again the clinical results are not disastrous, even if it's not perfect. Once again, you have this loss on GBR, and it's vestibular loss, so we don't have the 2 millimeters at the neck of the implant, despite the fact that it was highly satisfactory to start off with. So what we're going to try and do now is to give priority, if the ridge allows us to do this, to pre-implant reconstruction. So this is what you see on the top of the screen, and you can see if the anatomy allows us to do this. We prefer to use intra-implant splitting. Why? Because this allows us to move the cortical bone and the medullary cortical bone to the vestibular, so this means we can gain in width. Then we can place the implant at the same time, so the implant is going to base on a cortical medullary support, and we have to have an implant which is placed on the right axis, the lingual wall, so this gives us access to the implant. Then we place the implant 50 newtons, we submerge it, and then here these conditions are just GBR reinforcement, whereas if we hadn't done the splitting operation on the x-ray you can see on the left, then we would have had reconstruction GBR. So this is what we call reinforcement GBR, so this is favourable, and the split is accompanied by a fill of the gap using cancellous bone, and then a GBR to protect the valve and the implant, and to protect the implant from any inflammation after the operation. So the result at 2 years is highly satisfactory. If this isn't possible, then what we do is we opt for a pre-implant split. So if we can't place the implant in the proper conditions, here again what we do is we enlarge the ridge, we push it to the vestibular, we fill with a block of cancellous bone, allogenic cancellous bone, and then we cover it with GBR, and then we place the implant afterwards. So this is an operating technique which is a good alternative, even if obviously we haven't abandoned vestibular graft for the upper jaw. Now, the third thing that we've identified in this study as being very unfavourable is the positioning of the neck of the implant in vestibular. So this is something that's been shown by everybody who's worked on immediate loading. So we have to maximise the number of cases where we can use the palatal route. So sometimes we can use this in all cases where we have immediate aesthetic enhancement, extraction, implantation, and immediate aesthetic enhancement, or extraction and immediate loading. So for all of these protocols, we look for the palatal or lingual bone, and our implant is necessarily placed against this wall, and then when we have vestibular bone GBR, then obviously we have the proper anatomical and technical situation which gives us the best possible GBR results. So for the time being, these results are still being studied in our practice, so maybe next time we'll come back to you to present the results that we've obtained with immediate loading and immediate aesthetic enhancement. But basically I think we have all of the positive factors involved here: spontaneous regeneration of the socket, simultaneous GBR, and tissue which is based on the prosthesis and no longer subjected to pressure due to the closure of the flaps. So a final factor that we've identified with the bone morphotype, this is the fenestral type, and the question is, to compensate for this phenotype, can we have a larger or wider GBR? So here again, this is an illustration. This is the case that we started with. You can see that on both sides of the implant, the two teeth have roots which are fenestral, so a very limited bone thickness in the vestibular. So we've overcorrected this so as to try and gain a maximum result, but you can see that the morphotype here is not very favourable, and the GBR doesn't work here. So the GBR doesn't give satisfactory radiological results. So should we change techniques? Good question. This is a real question actually, because with the presentation we saw this morning, we saw that the benefit and the stability further to initial healing at 6 months of GBR obtained with non-resorbable membranes can be used, and it's probably this type of thing that we're going to be working on: either change the membrane to continue to work on GBR, or to add GBR to other techniques, because GBR is just one aspect of reconstructions which we can add to others. Splitting, for example, bone graft, segmentive systems, and zygomatic implants, and these implants, contrary to what we might believe, require a lot of bone. Thank you very much for your attention. So, do we have any questions in the room? Thank you very much, Arnaud and Marie-Pierre. No questions? Look at your 3D images, but to try and cooperate your results with your own studies, because we don't have all of this information on the 3D pictures. So very often we only have 2D for GBR. So it would be interesting to compare and contrast the results and see if you've obtained similar results or if it's us that haven't obtained satisfactory results, because we do have some disappointing results in some of the cases we showed you. Okay, well, thank you then. I think that we can just thank you. We have a short break now. We'll meet again at... there's a question. I jumped the gun. Well, if you don't raise your hand, I can't see you, so... Thank you very much. It was a super presentation. Great job. There are so many subdivisions that you could have mentioned as well. I've got 2 points that I'd like to raise. When we have a reconstruction, what's the trend? All the implants that you talked about, are they universal? Yes. Can we use less compressive implants? Have you studied that possibility or not? That's the first question. Second question, because here you're talking a lot about bone. This morning we had a lot of presentations on bone and mucus. Are these failures linked or not to conjunctive tissue, for example? Could we improve the results? Just to answer that question on the gingival biotype type. No, it's very rare for us to do that, particularly for GBR with the reconstruction that you're referring to. We don't include a new gingival surgery, or we will have a graft on the conjunctive or connective tissue in some cases, but that's extremely rare. So in most of the anterior cases, we have immediate enhancement in our protocol, simply with filling the gap, but without a connective or submerging the connective, and with some very satisfactory results. We're not certain about this, but we will be able to produce some data if necessary. It's very difficult for me to, with the in-cone implant, to use submerged connective tissue grafts. So to answer your question, we haven't tried to change the biotype since the results were satisfactory. So with regard to the proposal you made for the classification with type A, type B, and so on and so forth, typically for type A, this is unfavorable, you said. Could we think about mucus addition? So basically, could we add mucus? No, not necessarily. Well, pre-op or post-op? Well, no, my question is the relative failure of GBR. Can't we protect the site? Well, yes, I think we can certainly protect the site. I think we have to protect these sites, and we have to think about using submerged connective tissue. But since the situation is stable from a clinical point of view, it's always difficult for me to propose surgery to patients because if they are happy with their crown, they don't really want to undergo surgery again. So when it comes to our tranquility over the years, it's true, it could be a solution, but what we like with in-cone implants is the fact that the profile is a tulip shape, and this leaves a lot of room for natural connective tissue, so we don't necessarily have to add connective tissue. It's very rare. And there was another question about compression. So when we have a reconstruction GBR, compression that exists when we install the implant doesn't act on the vestibular because we don't have any bone, so it doesn't really matter. And I'm not sure that this would change anything with regard to the quality of the vestibular reconstruction. However, I think we should study this and we should study all clinical factors. I fully agree with you on that. Thank you very much. Another question, maybe? Yes, thank you very much. Thank you for casting doubt over all of my certainties, because in fact I've had more or less the same experience as you. I do a lot of GBR as well, so I'm an omni practitioner if you like, but I tend to see a lot of loss of mass, and I do a lot of grafts. So my question is, well, your study is not intraoperative, and at the end you talked about a pre-implant GBR where you have immediate loading with 50 newtons, and the result is more or less the same. So this shows that in your mind there's no difference whether you do it pre-implant with the biobank and a membrane, or if you do it intraoperatively. So basically the question is if this is corticalized, because the first experiences that I had when I opened up, it looked good, a bone, and when you open again with a biobank, I get the impression that I had cortical bone. So I was very confident with that, but I'm wondering whether we shouldn't use xenografts. With xenografts, we didn't show you this, but we've had some very satisfactory cases. We did show you some cases 11 and 21, but very often, like you, when we lift the flaps on patients whose sockets were filled with this type of bone, then it looked like a real mess, and then afterwards you have to do it all over again, so it wasn't at all satisfactory. And then with regard to GBR, we did show you, however, that in one case, if you remember, on the one hand we grafted, and on the other hand we did GBR, and just like you, when we opened it again, we found that the ridge was, well, it looked great. It looked great, the volume was good, the bone was vascularized, so everything was there for the implant to work well, and it was the case. But unfortunately, 2 years down the line, luckily it's only in 22% of cases out of all of the study, and in obviously 78% of the cases it's okay, but we did see this loss, and the question is, GBR is satisfactory in some cases, but it doesn't respond to mechanical constraints, so in some cases it's better to graft or to split rather than to do simple GBR, because the result is radiologically satisfactory. It doesn't mean that the GBR is not working, and you saw this cortical medullary bone, and this is sustainable over time, and we do get this with GBR, but in 22% of cases we don't have this. Okay, thank you very much. Great pleasure. Well, thank you very much. Thank you so much. I think it was very interesting to study all of your cases and to come clean. It's a bit scary, actually, because I think if we were to do the same thing in our practice with our cases, I think we would have more than 22% failure rates. So thank you very much for being so honest, because I think it was very constructive, and it's very important to study failures and to study other people's failures as well. Now, in your study, I'd like to know if you took account of the occlusion strength. So no, we didn't. So that's why we have so many cases. We don't control occlusion at all, and this is really the black spot in our study. But thank you very much for raising this. In fact, this study wasn't to show that every time it fails. No, just to reassure you what you do with the biobank. I think you have to continue in the same vein. So the study aimed to show that we can succeed, and that we are pushing things to the extreme so as to improve what we're doing. It's like a game. This is a big discussion that we have amongst ourselves in our practice, to be able to position a surgical technique or to move on to a different surgical technique. And you need to validate what's been done in the past, and you need to validate the different techniques used. So GBR is a very good surgical technique. We have to continue GBR, but the problem is that when you assess this bone gain, then we have to know exactly what we're assessing. You have to look at all of the situations, all of the different conditions in every human mouth. You can't compare a toothless posterior sector to an anterior sector, for example. We saw some very good cases this morning with teeth tases, and for me this is not atrophy. We can't really talk about atrophy of the upper jaw because don't forget you have a certain level of perfusion which exists already. So what we wanted to explain to you through the study is we shouldn't be dogmatic about things. We shouldn't say that this solution has that or this situation corresponds to this solution, and you can't say that guided bone regeneration with biomaterial and any other materials, xenograft or anogenic graft, is better than another technique which you might use, or better than another material. That's not the aim of the study. The aim of the study is to show that when you have a patient, you have to be able to alternate between different surgical techniques, and this is, on the contrary, what we tried to do. And I think that this does show, and this does really prove, at least for our practice, that we need to use GBR still, and there are indications for GBR. So we've used regeneration in other situations in reconstruction cases, and obviously you have to add it to other forms or techniques in reconstruction, and they might be adapted to certain clinical situations. We've seen some wonderful cases this morning, for example, but when you have GBR plus splitting, for example, we see that technically speaking the result is highly satisfactory. So it's not really a failure as such. It's all about talking about different techniques, and we had that case where we had minus 5.5, and this weighed heavily on our statistics, but this creates some big deviations when you have one case which is particularly bad. But basically we have to look at what's going on in the vestibular area, and in terms of reconstruction there's a notion that we have to focus on is time. Time plays a role as well. For example, we have to include vascularization in the time factor. For us, vascularization is very important. How can we maintain vascularization over time? So if you take teeth out, and you see there's no vascularization, there's no bone. Now Bertrand earlier on showed us the use of this early socket. So when do you extract, when do you implant? And Bernard's case showed us that the more you have socket bone, the better it is. Less you have bone in the socket area, the less it tends to succeed. I think everybody's ready for a coffee, aren't they? I think, oh, there's one more question. I had a question. Yeah, I'm here. Have you created a decision-making tree or flow diagram, if you like, so as to decide when you have to change methods? So in pre-implant situations, and to decide on whether you're going to work on intraoperative implants, for example. Well, for the time being, it's a tree with one single branch. It's basically it's based on the conclusions of the study that we just presented. So reconstruction GBR, we prefer to have a prior surgical reconstruction phase and then implant. So this is basically what the study shows, and also we use membranes. Another observation, which is maybe a bit more technical for some of us, based on the morphotype, because sometimes this explains, now even if we don't systematically pose the implant in the vestibular in type A cases, which are very fenestral cases, so maybe it's not a problem with the technique as such, sometimes it's a problem with the morphotype of the patient. Let's take one final question from the back of the room. Yes, thank you very much for this presentation. I'd like to ask you if you've taken advantage of the 2-year COVID period to see these patients again 4 years later and to see whether they were stabilized or not. Well, obviously, we have a problem with data retrieval and data processing, so I have to find a student. It's exploitation of students, really. I have to find a very good student to do this, so obviously the problem is the students don't like necessarily to work on statistics, so it's hard to find students that like digesting and processing all of these statistics. So we'll be back again at 4:50. 4:50.
Si vous me laissez le micro.
Le micro, je vous le rends maintenant.